Hello. Good evening, all. It worked. Great. Got a full house, and that's fantastic. I was looking forward to a full house, and we have it, so that's fantastic. Great to see you all here. My name is Harry Gijbels. I'm a senior lecturer in the School of Nursing and Midwifery here in the university, and on behalf of myself and the school, and on behalf of the School of Social Studies, Applied Social Studies, and the newly formed Irish Network of Critical Voices in Mental Health, and the Irish Institute of Mental Health Nursing, who have also sponsored this evening, I would like to extend a warm welcome to you. I've been looking forward to this evening for a while now. Robert Whitaker arrived in Ireland last Thursday, and I've been sort of following him around. And it's been interesting, challenging, some fantastic audiences throughout the country, so it's good to see a full audience here in Cork too. I'm not going to say a great deal at this stage, probably not at all, but I'll just take you through the proceedings for this evening. So I'm going to ask Professor Fred Powell to say a few words in a minute, and Fred will then introduce and welcome Dr. Pat Bracken, consultant psychiatrist from West Cork, who will say a few words, and that will lead us into the main guest for this evening, Robert Whitaker. And then Lydia Sepuna will end proceedings. So hopefully we'll also have a good discussion at some point. So if everybody will try and keep their talks to the minimum, and we'll have a great debate. So it's hopefully an intriguing, interesting, irritating, challenging talk this evening, and might raise a few questions here and there, might provide some answers. But anyway, enjoy yourselves, and can I ask Professor Fred Powell to say a few words to you. Thank you.
I'd just like, as Dean of Social Science, to welcome everybody to this really important gathering. An event like this puts the university in a location where it should be a lot more, and that is talking about the issues that really affect our lives. And mental health is one of those central issues. And we have a speaker tonight, Bob Whitaker, who is one of those rare inspirational writers and thinkers. He has been greeted in this country with extraordinary enthusiasm and warmth. And I've had the privilege of talking to him earlier today, and he comes across as a truly remarkable person. Reading his books, looking at them, his skill as a writer, but also his capacity to challenge conventional ideas is of enormous importance. People like Bob Whitaker really keep the world a civilized place because they offer us not just a critique, but hope. As they always say, at the bottom of Pandora's box is hope. Before Bob speaks, Dr. Pat Bracken, who's a consultant psychiatrist in West Cork, is also going to speak. Pat is a writer as well as a psychiatrist. He's somebody who dares to think differently, and I think he is enormously valued and respected in this country because of his moral courage. I'd also like to thank my colleague Lydia Sepuna and Harry Gijbels, who have really had enormous courage in this university in putting mental health at the centre of the agenda, which doesn't necessarily please everybody. The Irish Network of Critical Voices in Mental Health is a really important organisation. It's important that we think critically about these social issues. And I can think of few social issues that are more important than mental health. So can I welcome you all? Can I welcome our speakers? And can I ask Pat to address us?
Thank you very much. As Harry was saying, it's inspiring to see such an attendance tonight. So thank you truly for everybody for coming out and coming to this event. I would genuinely like to sincerely thank Harry Gijbels and Lydia Sapuna for organising this, because they've done a fantastic job, not only in regard to this event tonight, and to Bob's visit to Ireland in general. They've really been right in the middle of organising that. But in regard to the 2 recovery conferences that have been held over the last 2 years in this university, and these events really, which drew very, very big attendances, really gave rise to the Irish network of critical voices in mental health. And I think Harry, when the history of this is told in years to come, Harry and Lydia will bear a lot of the credit for this movement. It's not only credit to Harry and Lydia, but also to their respective academic departments here at UCC, the School of Nursing and Midwifery, and Fred School, the School of Applied Social Studies. And they in their support for Harry and Lydia in organising events, in opening up the university to community organisations and to individuals to come together to discuss important social issues like this. They've shown a true example of how the university can be relevant to its local community. It serves to provide a space where important issues can be debated and analysed. And I think that is a very, very important aspect of the function of a university in a society like ours, particularly at this moment in time when we're going through such radical social change. To have a university that is open to the community in this way is extremely important. And believe me, it doesn't happen everywhere, and it's not necessarily supported by every aspect of the university. So it really is to the credit of the School of Nursing and Midwifery and Applied Social Studies that they have sponsored this meeting. Apart from Lydia and Harry, many other individuals and groups have been involved in organising this meeting, but also involved in the movement that we're seeing emerge here. We're very lucky in Cork, I believe, to have a vibrant community of mental health activists. We've John McCarthy and Mad Pride, which has really now become a national organisation and is a fantastic, creative voice for people in mental health. And it's opened up different ways of looking at the whole issues around mental health. So, I mean, we're lucky to have people like John, Mad Pride, Jim and Mary Maddock with Mind Freedom, and people from Eile are here as well. I'm going to leave out all the other wonderful individuals and organisations, but I think you get a sense of that we have here in Cork a huge resource around mental health in our community, people campaigning, provoking debate, discussing, etc. And all of these are now coming together in this movement of critical voices in mental health. And I'd like to just focus for a few moments, if you'd indulge me, on this word critical. Because I think it is important that we get our head round it at this stage. And often there's a sense that, oh, you're overly critical, that you're being too negative by using the term critical in the first place. I'm proud of being one of the founder members of what's called the Critical Psychiatry Network. We formed this, myself and colleagues in Bradford, over 12 years ago. We came together when I was working there. We were working psychiatrists in the NHS in the UK who were very dissatisfied with the way our profession was going. We came together and we started a group which became the Critical Psychiatry Network. And this has grown over the years. There's now over 100 psychiatrists, mainly in the UK, but it's an international organisation as well, who share ideas and have regular conferences. We don't agree about everything, but in general we write, research, campaign on issues to do with psychiatric power, the dominance of the narrow medical vision, the baleful influence of the pharmaceutical industry on our profession, and we seek to promote and collaborate with the growing international service user movement. If any of you are interested, if you Google Critical Psychiatry Network, you'll get onto the web page of the organisation. There's lots of documents and information in that site. I believe that this is a positive and outward-looking movement. For me, critical psychiatry is different to anti-psychiatry. It is about critique. But think about that word critique. Just as the great Enlightenment philosopher Immanuel Kant, when he wrote his book, A Critique of Pure Reason, Kant wasn't criticizing reason, believe me. He was one of the great Enlightenment philosophers who was actually shaping up to found a whole cultural movement on the basis of human reason. But what he was doing in a critique of pure reason was trying to explore the nature and identify the possibilities and limitations of human reason. And I believe that this is the kind of way in which we use the word critical when we talk about a critical mental health movement. Is about looking at the assumptions behind the theories and practices of psychiatry, looking at the values that are often unexamined, and looking at the nature of power in the field of mental health more generally. For me, as I say, this is not a negative activity. It never has been. This is something extremely positive. It is a move away from dogma and towards openness. It is a move away from paternalism and towards democracy and collaboration. In the end, it is ultimately a move towards transparency. By examining assumptions, by examining ideas, by examining values, we start to see what's really happening in a field of activity like psychiatry and mental health. I would go so far as to say that critical thinking is now a necessity in the field of mental health, but not only in mental health. What we have learned in Ireland over the last number of years is that all professions, whether it's the church, politicians, economists, bankers, builders, doctors, need to develop the ability to think critically about where they've come from, on what ground they are working when they are pronouncing and acting in different ways. We need to start thinking of our professions as having the ability to stand back from their assumptions, their standard view, the perceived wisdom, and think critically about their own history. So I believe that critical thinking should now be part of the training of all professionals, particularly those like myself who have the power to categorize people and to alter their lives and relationships in serious ways. But I think we also need to be critical, and we need to develop critical thinking when it comes to science. And this might sound odd, because science is often thought about as something outside of society. It's something neutral, detached, objective, impartial. This is sometimes the case. But more often, what gets researched, by whom, and under what conditions are factors that are often influenced by straightforward financial interests of one sort or another. And I would put it to you that this is what has happened in the field of psychopharmacology, which has all of the apparatus of science, it has all of the paraphernalia of a scientific discourse, but it has been shaped according to certain financial interests in the last 20 years. And this story, the story of psychopharmacology, is the story that Bob will address this evening. Do we need to hear this story? Do we need to ask deep questions of the dominant model in psychiatry? Do we need to interrogate our treatments, and in particular the drugs that we use? Yes. By God we do. I want to quote to you from last week's Lancet journal. This is one of the major medical journals in the world, one of the 5 major journals in the world. This is an editorial from the Lancet of last week. Figures published by the Archives of General Psychiatry on February the 7th of this year will be of deep concern to every mental health practitioner. In their systematic review of early cardiometabolic outcomes, Deborah Foley and Catherine Morley, two researchers from Australia, set out the dramatic effects of antipsychotics on the physical health of those taking them for the first time. The authors record, for example, that, quote, the average weight gain after 6 to 8 weeks taking olanzapine was 5 to 6 kilos, and that at 8 weeks there was a significant increase in insulin level, insulin resistance, and glucose, cholesterol, triglyceride, and C-peptide levels. This is the Lancet now. It is no surprise, therefore, that people with severe mental illness have lives 16 to 25 years shorter than does the general population, and that coronary heart disease, not suicide, is the major cause of death. And the Lancet goes on to say, in any other scenario, the responsible physician's response would be to seek an alternative. However, for mental health professionals, the mainstay of treatment for psychotic illness is, as it has been for over half a century, antipsychotic medication. So, when we're looking at figures like this, when we're looking at a reality like this, in terms of physical health, we need critical thinking desperately in the field of psychiatry. And the critical mental health movement is about seeking the alternatives that the Lancet is saying we should be looking for. When we're faced with a reality like this and the demand for alternatives, they're not coming from within psychiatry. They're coming from meetings like this, organizations like this. We need ways of finding different ways of promoting well-being and looking at how they can be found. I would say to you, if you want to see alternatives starting to happen in action, after this meeting tonight, there's a concert in the pavilion. Susan McKeown is singing there, and Will Hall, who's here, is going to say a few words. Will is an inspirational voice from the United States, who is part of a large growing number of service users and survivors who are promoting alternative ways of coping with psychotic experience. If anyone is inspirational, I think, around this, it's someone like Will. But I would really recommend the concert as well tonight. Susan McKeown sang last night in the West Cork Hotel in Skibbereen, and it was an inspirational and beautiful evening. Her songs are all about mental health and mental illness, and different themes merge in together. John McCarthy's also, I hope, going to read some poetry down there if he feels up to it, but it'll be a very, very good evening. But I say that because this is a positive movement. This is a positive seeking for alternative ways of helping people stay well. Bob Whitaker, who's going to speak now, is also part of this movement. I believe his two books, Mad in America and The Anatomy of an Epidemic, have contributed substantially to this debate and that. Bob is a very well-established and acclaimed science journalist. He's from within the scientific tradition. I've heard him speak already today, and he's talking the science. He's using the science of psychiatry itself and looking critically with that at the outcomes for people with serious mental illness. I am personally very grateful to him that he has turned his talents to this field, but because, as I said already, by God, do we need it. He has accumulated many awards over the years, and he was a finalist for the Pulitzer Prize in 1998. He's a brilliant speaker, and I'm sure you're going to enjoy and be challenged by his contribution tonight. Over to you, Bob.
First of all, thank you all for coming. It's been an extraordinary 4 or 5 days here in Ireland. And I have to tell you, so I've been speaking in Dublin Athlone, as I'm pronouncing that right, and now a couple of days in Cork. And one of the things that has so impressed me is how people coming to these events, it's as if Irish society really wants to think, does this model of care that we have for dealing with psychiatric distress, is it working? And if not, what might we do differently? And I have to say, it seems here that there's more of a movement than I have seen anywhere, more than in the United States. It's really remarkable. You see it in your press. You see it in sort of the radio interviews, these large turnouts. This critical psychiatry network, I think, is an extraordinary force for change. So, and first of all, I've been extraordinarily well welcomed here, too, so thank you. But I've really drawn a lot of inspiration for these 4 and 5 days. And a night like this is an inspiring night for me as well, so thank you all. I also want to thank the groups that made this possible, the School of Nursing and Midwifery here at the college, the School of Applied Sciences here at the college, the Irish Network of Critical Voices in Mental Health, and the Irish Institute of Mental Health Nursing. And again, you just see in those inviting me here, it's a nice broad-based group. And thank you both to Dr. Bracken and Professor Powell for those wonderful introductions. Those were really nice. Now, I have to tell you, so I've been giving this talk. And I've been going around to different venues, and I've been giving this very technical scientific talk. And I've been looking at, well, what do we know about the biology of mental disorders? What do we know about how drugs affect the brain? And then I've been going through the long-term outcomes literature and looking at how drugs shape the long-term outcomes literature. Very technical talks. And then Harry, on the way over here, said, why don't you give a different talk tonight? So I'm going to wing it. And if this talk bombs, talk to him, all right? What I really thought I would do tonight is give more of a talk about how did this medical model develop? In other words, how did our understanding of psychiatric problems, the one that we embrace now, how did it develop through history? That's number one. Number two, is it true? In other words, are the conceptions of mental illness and psychiatric distress that have been told to the public, are those rooted in good science? Will science back up that storytelling? Third, then, I will look at this. Is this model of care really working? In other words, is it working for us as a society? Is it helping ameliorate psychiatric distress in our society or not? And then I think finally, after we do that, I'll talk a little bit about some long-term outcome studies that you probably haven't heard about, and then we'll find out why. And then finally, we'll look at, after that, is there a new model, a new understanding that maybe we could begin to embrace that would offer a way forward? So, but do bear with me. This is like a little bit of trapeze artistry because this was not the talk I planned. Okay, so how did we get to the medical model? How did it arise, this understanding that psychiatric disorders are biological disorders and we have drugs now that fix chemical imbalances? It really comes in 2 stages. If you go back to 1955, a drug called chlorpromazine. In the United States, it was branded as Thorazine, and in Ireland, it was... Thank you. And this arrives in asylum medicine in the mid-1950s. And just so you know, when that drug initially arrives, it is heralded for 2 things. First of all, it's called a major tranquilizer. It is not called an antipsychotic. Now, second of all, by the way, in 1949, 6 years before the arrival of chlorpromazine, a surgical invention in psychiatry won the Nobel Prize in Medicine. That surgical invention was lobotomy. So Igaz Moniz invented lobotomy in 1939, and 10 years later, he won the Nobel Prize. And the idea with surgical lobotomy was that you could neatly pluck madness from the brain, and that was the idea. And you could do it without causing much side effects. You're either going to improve the person or even cure madness. And this was seen as this extraordinary, remarkable brain surgery. And you all know what frontal lobotomy was. You basically scramble the frontal lobes, which is the part of the brain that really makes us most human. If you look at a monkey brain or an ape brain and you look at a human brain, they're very much alike except for one thing. The frontal lobes of the human brain are more pronounced. Anyway, 1949, surgical lobotomy wins the Nobel Prize. When Thorazine or chlorpromazine is initially introduced into medicine, it is actually talked in a positive way as producing a chemical lobotomy. And you can see why it might be done in that way, why that might be seen as beneficial, because we had this surgery that caused this change in being, and lobotomy certainly caused a change in being, that was seen as beneficial for, quote, the severely mentally ill, and chlorpromazine was seen as causing something of a similar change. People became less engaged in the environment, that sort of thing, more sedated. So then so it was known as a major tranquilizer, and about 8 years later, there was the first well-controlled study of chlorpromazine, and it was a 9-hospital study. It had 4 arms. Actually, there were 3 of these major tranquilizers being tested against placebo, and what the researchers concluded is at the end of 6 weeks, those treated with chlorpromazine or one of these other major tranquilizers were doing much better than the placebo group. Their psychotic symptoms had abated more. And they said this is not a major tranquilizer, this is an antipsychotic. The name shifted at this moment. This is 1963. And you can see in this word change a different conception. A major tranquilizer, of course, is something that's like sedating you, sort of knocking you down in terms of your response to the environment. This now says it's fixing, it's an anti-drug, like an antibiotic, fixing something wrong in the brain. And this is the beginning of really biological psychiatry conceptually. Then we get antidepressants and anti-anxiety agents. And because of this name change, researchers now once they start identifying how the drugs act on the brain, they start now looking for the opposite thing. So for example, here's what I mean. Antipsychotics, they found in the 1960s, work by blocking dopamine receptors in the brain. So because they had named them antipsychotics, researchers began to say, well, maybe schizophrenia is due to too much dopamine in the brain. But that conceptualization of mental illness arose in large part because of this name change. These were no longer sort of tonics, sedatives. They were antidotes to a disease. Anyway, the seed for biological psychiatry is now planted. But in the 1960s and 1970s, there was a lot of talk about social psychiatry. In the United States, we still had a lot of Freudian conceptions about mental illness, psychoanalytic theory, etc. But then what happens in the 1970s? And so much of this does emanate from the United States. In the 1970s, we got an explosion of therapists. We had social workers beginning to offer therapy, psychologists. We had all sorts of alternative type of therapies. Even some Buddhism begins to be a little popular. And all of a sudden, psychiatrists who had been used to giving talk therapy, at least part of it, were now in competition with all of these other therapists. In other words, there was this economic condition happening. That's one thing that happened in the 1970s. Second, the drugs actually, those first generation of drugs began to fall out of favor. And the drugs that really fell out of favor were Valium and the benzodiazepines. Do you call it Valium in the UK? So if you go back in terms of the first generation drugs, Valium and the benzos get introduced in the early 1960s to treat anxiety. This is the distress sort of ordinary people feel. And the benzos become really popular drugs. But then in the 1970s, researchers start to understand, and there's reports that these drugs can be addictive, and once you're on, it can be really hard to get off. And so what happens in 1970s? And there's another problem that begins to surface in the 1970s. It became clear that antipsychotics could cause something called tardive dyskinesia. So people are on antipsychotics, and you'll start to see certain people where their tongue, for example, will be rotating in and out of their mouths, and this is involuntarily, and this is a sign that the drug is damaging a part of the brain called the basal ganglia. So all of a sudden, in the 70s, even as psychiatry was faced with this competition of other therapists, their drugs were falling out of favor. And you can read in the American Psychiatric Association documents this sense of, we are now fighting for our survival. How can we allow our discipline to thrive again? How can we survive? And here's what you can see they said. They looked at themselves and they said, what is our advantage over other therapists economically? It's our prescribing powers. That's number one. And number two, they said, what is the image that has such a powerful pull on us ideologically in the United States? And it's this image of the white coat. It's the doctor in the white coat. And you can really see psychiatry in the 70s saying, We need to sort of embrace the medical model, embrace our role as doctors, and inhabit that role sort of publicly, as people in white coats, with pills, with magic pills like those in infectious medicine, as a way really to save psychiatry, to rebuild it up. Now, if you look, we have this diagnostic and statistical manual. It goes back, I think the first one is in the early 1950s. It talks about neurotic disorders, that sort of thing. As this was happening in psychiatry, they said, we're going to change the DSM. And we're going to move from this sort of neurotic Freudian conceptions of mental illness to a medical model. And we are going to declare these diagnoses medical diseases. And so they come out with 1980, they come out with DSM-3, and that it's very much a medical textbook. We're going to say that these are discrete disorders and that they have these discrete treatments, these discrete drug treatments, and we are going to call them diseases of the brain. The important thing here to understand this from a social history is there was no understanding, there no new revelation about the biological causes, if there are such things, of mental illnesses that led to DSM-3 and this conception of the medical model. It was done really for professional reasons, as a way to get psychiatry to rehabilitate its image, in essence. And you can see this. So, for example, in 1980, the American Psychiatric Association establishes its own press to begin to tell this story of biological psychiatry, of the medical model. They also, at this time, really began joining forces with the pharmaceutical industry. And you can see them saying, our interests as sort of prescribers of drugs coincide with the makers of these drugs. And now there had already always been, or for a number of years, a lot of money flowing to the American Psychiatric Association from the drug companies. But now the floodgates really opened. And for example, the APA is part of this new story, so it establishes this press, the American Psychiatric Association Press. It establishes a press office, and it begins holding annual meetings annual sessions where it courts reporters, it brings them in, and it starts talking about these extraordinary advances they're making in understanding the biological causes of mental disorders. And they got funding from the pharmaceutical industry to start running media training sessions. So they went around to different sort of local chapters, state chapters, and psychiatrists could now go to media training sessions and learn how to speak this new story of biological psychiatry. And it was how to do interviews with the TV, how to talk to the press. And those were, in essence, funded by the pharmaceutical companies. And there was one other thing that began to happen in the 1980s, is the prestigious doctors, psychiatrists at prestigious academic institutions, Stanford, Harvard, Johns Hopkins, Duke University, etc., they began, in essence, working for the pharmaceutical company. They began taking money to be consultants, speakers, serve on advisory boards, that sort of thing. So there was this joining of interest. And you can see a little bit about the storytelling machinery that is now springing up. Because in the United States, these are the people we trust to tell us the real story about medical disorders, right? It's the psychiatrists at academic medical institutions. And we had no idea they actually now were getting money from the pharmaceutical companies and even training to tell the right story. So this takes place in the 1980s, this sort of this joining of this unholy alliance. And there, by the way, there's one other storytelling voice that forms in the 1980s that is so important as we try to understand why we believe in this medical model. And it was the National Alliance on Mental Illness. Have you all heard of that organization by any chance? It's a parents' organization, and it forms in 1980s really as a reaction to the schizophrenic mother idea of schizophrenia. So in the old Freudian idea, the idea was someone became schizophrenic because they had this mother who was so problematic. The mothers of schizophrenia children didn't like that. And so they really wanted to embrace this medical model where it wasn't the mother's fault, and I don't believe it's the mother's fault, but this sort of no fault vision of schizophrenia. They form in the 1980s, and the pharmaceutical industry right away says, aha, they can be a very good sort of storytelling partner. And they start courting it. NAMI, the American Psychiatric Association, you can see documents saying, we need to bring NAMI into our storytelling apparatus as well. So we got these very three strong voices operating together, all wanting to tell the same story. Psychiatry, for financial reasons. Pharmaceutical company, obviously for financial reasons. And NAMI really sort of for this desire to escape from this cloud of the schizophrenic mother. Now in I think it was 1984, Nancy Andreasen wrote a book called The Broken Brain. Nancy Andreasen later will become editor of the American Journal of Psychiatry. If you get a chance, read that book. This book, which was extraordinarily popular in the United States, gives us a new image of mental, quote, illness. And what she says in this book is, our diseases, schizophrenia, bipolar, depression, are real diseases just like diabetes and cancer. They're diseases of the brain. They're planting the biological flag. And if you can read, and the implication of this book was that this had been discovered, that we had discovered these biological causes. But if you read that book real closely, she says this, we haven't really discovered that yet, but we're confident this revolutionary advance in knowledge will occur. So you can see now at this moment we have this divergence. We have a story beginning to be told about these biological mysteries of psychiatric disorders are being unlocked, but it's not really being driven by scientific advance. It's being driven by economic and these other factors. And we're going to get this story going even as the science was lagging behind. Now we get in 1987, Prozac arrives on the market, and this really kicks off this medical model. And just for example, in the United States, in 1987, we were spending about $800 million on psychiatric drugs in 1987. 20 years later, we spent more than $40 billion. So we had this 50-fold increase in spending on psychiatric drugs. That's a story of extraordinary commercial success. From a capitalistic point of view, fantastic, a 50-fold expansion of your market. What was happening with Prozac's introduction? It's really fascinating. Ordinary distress, up until this time, if you would have looked at books on what depression is, depression in 1980 is something that strikes people 35 and older. It's basically a middle-aged disease or disorder. It's pretty rare. It's like 1 in 1,000 people a year, that sort of thing. You know what hits people younger than that with sort of this ordinary distress or this sort of more ordinary distress? It's anxiety at the time. Why did they have to reconceptualize anxiety as depression? Here's why. The benzodiazepines had been, you're not supposed to take them very long. And benzodiazepines were for anxiety. So literally there was this desire as Prozac came to market to reconceptualize sort of the milder distress we feel. And I know about you, but sometimes I really have trouble distinguishing between depression and anxiety when I'm feeling that discomfort. But the idea was we were now going to start defining that discomfort that hits younger people sometimes, larger swaths of the population, as depression. Now, as this is going on, Prozac is actually being tested in Germany. And it is not doing well. In fact, it's not beating placebo by much, and it's causing so much suicidal ideation and, in fact, some psychotic responses that the German regulatory agency says this is not a safe or effective drug. They don't allow it on the market. They decide it shouldn't be approved. But this is going to be the drug that launches the modern psychopharmacology era. How does it happen? What happens is, as it comes into the United States and is tested there and is brought forth to the FDA, a lot of those problems that showed up in the German studies, the suicidal ideation, the psychotic episodes, were reclassified as return of depression. They were buried. And because they were buried, all of a sudden the safety profile improved, and there was a little bit of, sort of efficacy over placebo in the drug. It gets approved for the market. And what is the story that is then told? So here's this drug, barely beat placebo, lots of safety problems, and what do we hear? this drug, and this is a story being told by people at Harvard Medical School, great schools, is so much safer and more effective than the old drug. In fact, we got the story, it will make you better than well. Did you hear that here? And we even then went another step further. We heard that we were learning so much about the brain, we could do something called cosmetic psychopharmacology was looming on the horizon. And pretty soon, you could order up whatever personality you wanted. That was going to be the future. I swear to God. And people even sort of wrung their hands like, is this a good thing? Everybody will be too happy. So, and then we also heard, of course, the story that these drugs fixed a low serotonin. Depression was due to low serotonin, and these balance this chemical. That's why you needed to take it for life, like insulin for diabetes. And this new story, the chemical imbalance story, takes root. There was a recent survey in the United States about the chemical imbalance story, and 87% of Americans now understand that depression is due to low serotonin. That storytelling has been successful. An equal number now understand that psychotic episodes and schizophrenia is caused by an overabundance of dopamine. That it's a chemical imbalance story. So you see this success. Anyway, just going a little bit more with this commercialization story, watch what happens. So we get, and I'm going to tell the story in the U.S., but you're starting to see this in Ireland as well. So we get the SSRIs, right? And about early 1990s, the pharmaceutical companies began holding meetings, and they said this: the adult market for SSRIs, that's the selective serotonin reuptake inhibitors, is now saturated. So where's the untapped market? Kids. And they literally had conferences about how do we start tapping this market. Now, just one thing. The antidepressants in kids, they failed time and time again to even prove effective over the short term, but that really didn't stop things because there was this market to be exploited. And these consultants, speakers, advisors from the major medical schools said this: we didn't used to think that children suffered from depression, but we have now done new studies and now we know that they do. And when you hear that, and this was presented as this scientific discovery, what you're hearing is a market developing. Okay, next thing, what do we get? We got the atypical antipsychotics. So we used to have Thorazine and Haldol and the old standard neuroleptics. Beginning in the sort of mid-1990s, we got these new wonder drugs, atypical antipsychotics. Risperdal, Zyprexa, or olanzapine, which was what Pat was talking about, and we get these new drugs. They were said to be so much safer and more effective than the old drugs. By the way, my reporting on this whole story began with the atypical antipsychotics. We had this story about how much safer, how much more effective they were. So what I did is I filed a Freedom of Information request with the FDA. And I said, let me see what the FDA thinks about these drugs. There were two things. The first drug for regular use, atypical, that came on the market was Risperdal. Was that the first one here as well? Beat Zyprexa? Risperdal, so much safer and more effective. And I read the FDA review. You know what the FDA review said? Trials are biased by design against the old drug. There is no evidence this drug is safer or more effective than the old drug. So right from the beginning, there was this difference. The scientific literature was saying how safe they were. The FDA is saying, you biased your trials by design. The other thing I looked, just so you know, I looked at the death rate in those clinical trials. Of these new, safe, and effective atypicals, I calculated the death rate. 1 in 135 patients put on the atypicals in those trials, Zyprexa, Risperdal, other drugs, died. It was one of the highest death rates you've ever seen anywhere for a non-fatal thing. A lot of it had to do with suicides, people being switched from drug to drug. But nevertheless, those deaths never reported in the scientific literature. After the atypicals came to market, we had the same thing. A new disorder suddenly appeared in American journals. You know what it was? You don't have it yet, but you're going to get it. Juvenile bipolar disorder. So where did juvenile bipolar disorder come from? Prior to... Sure. Can you hear me? No. So prior to this time, the understanding was that juvenile bipolar disorder just did not happen in prepubertal children. But again, they had these atypicals. They needed a new market for them, right? They needed to have a market. They want to get into kids. They paid a guy named Joseph Biederman at Harvard Medical School about $2.6 million over the course of the next years to create this new entity. And there's actually been, I've got some documents where he's under testimony in certain places because they're getting sued, the manufacturers of these drugs, in which he says this. We used to call these kids as suffering from oppositional defiant disorder. I reconceptualized that as bipolar disorder. It's a subjective sense to it. And if you look at the documents, here's what he says to the maker of Risperdal. He says, I'll validate this. I'll run continuing medical education programs. I'll get other doctors to say that, yes, this is a real brain disease. That's number one. 2, I will show that Risperdal is effective in children for this new disorder. 3, I will show that it's chronic and you need to take Risperdal for life. And those documents are out there. And what I'm saying is, you can see here a commercial story unfolding. There was no discovery that kids, there was a marker for juvenile bipolar disorder. That's not what happened. How great was the marketing of atypical antipsychotics in the United States? This story should be written up in business journals. Remember, antipsychotics were always seen as having really problematic drugs. They had a lot of side effects, right? And they could only be used with these serious disorders like schizophrenia. That's the only time you might get this positive risk-benefit analysis. So a narrow market. In 2009, I think it was, antipsychotics were the top-selling class of medications in the United States. They generated more revenue than any other class of medication. I'm not talking about just psychiatric medications, heart medicines, you name it. That was the top-selling drug in America. That's a story of great commercial success. Finally, the other thing, and then we'll get into the second part of this thing, is we've had, as you know, this great expansion of the DSM. That's the Diagnostic and Statistical Manual. 1980, that was the one that put its flag in the concrete saying biological psychiatry is here. These are discrete disorders. Then we got DSM-3, and we got some others added. DSM-3R, was in 1987. I think we get DSM-4 like in 1995 or 96. Each time there are new disorders added. Pat, you know how many are in DSM-4? Is it 297? Okay, but here's the nice thing. You're all in DSM-4, okay? Read it, you're all there. You can find several places where you can get diagnosed. You can see why. It brings in more people into the marketplace. We have DSM-5, and now God knows what's going to happen with DSM-5. They're talking about being able to diagnose like the early warning signs of psychiatric distress. Okay, first part. That's sort of the commercial story. Now let's look at this. Is the chemical imbalance story true? And you've all heard this story, right? So let's look just at the low serotonin theory of depression, where it arose from, how it was investigated, and what they found. Here's how Prozac works in the brain. You have a presynaptic neuron, right? And that neuron, releases this neurotransmitter we're going to call serotonin into the synaptic cleft, right? And then that's that small gap between neurons, and then it binds with receptors on the postsynaptic neuron, like the usual analogy or metaphor, like a key into a lock, and that excites this neuron, and that's the way the message is passed. Now, the brain needs to cut that message. It needs to be a nice, crisp message, so it has to remove serotonin from the synaptic cleft. It does it in one of two ways. An enzyme either comes along and metabolizes that serotonin, and that metabolite is carted off as waste and will show up in the cerebrospinal fluid, or it is taken back up into the presynaptic neuron via reuptake channels. What Prozac does is it blocks the reuptake channels. That's why it's called a selective serotonin reuptake inhibitor, so serotonin now remains longer than normal in that synaptic cleft. Okay, so that theoretically increases serotonin, so researchers said, aha, maybe people with depression have low serotonin. And beginning in the 1970s, actually, they investigated it. And here's how they investigated it. I told you that there's these metabolite levels in the cerebrospinal fluid, right? So what they did is they measured those metabolite levels in depressed patients, and what they found is that there was like a bell curve. And it's like number of metabolites per, I don't know, some sort of tiny bit of fluid. And a bell curve meaning there was some people with low amounts, some people with medium amounts, and some people with high amounts. Then they did the same thing with, quote, normals. And what they find? That bell curve was the same. Okay? There was no real difference between the bell curve of depressed patients' metabolite levels and those in, quote, normals. So the NIMH actually hypothesized, after they found this out in the early 1980s, is, well, maybe what happens is there is a subgroup of depressed patients that have low serotonin, and it will be that subgroup that responds most to the drug. Because as you know, many people don't respond to antidepressants. So that was the theory. It's just a subgroup. So they ran a study in the early 1980s. They took the metabolite levels, and the hypothesis was it would be those with the low metabolite levels that have the best response. What did they find? There was no relationship between metabolite levels and response. Those with high levels were just as likely to respond as those with low levels. So in 1984, here's what the NIMH declared. This is before Prozac comes to market. Elevations or decrements in the functioning of serotonergic systems per se are not likely to be associated with depression. That's 1984. Now, after Prozac came to market, there was a lot of other ways they tried to assess whether people with depression had low serotonin levels. Time and time again, they did not find it to be so. So, for example, in 2000, there was a textbook called Essential Psychopharmacology. It's written by Stephen Stahl. He's a molecular guy. He believes in molecules and moods, but here's what he writes. There is no clear and convincing evidence that monoamine deficiency, serotonin is a monoamine, accounts for depression. That is, there is no real monoamine deficit. And if you want to get the latest updated story on this, there's a paper that was published, I think, in August of last year by Eric Nestler. He's another molecular guy. I think it's called Mood and Molecules. He goes through the long history of the search for the low serotonin in depression, and he says, it's not there. We didn't find it. Anyway, I could tell you a similar story about the dopamine theory of schizophrenia. Did they find that people with schizophrenia had overactive dopamines as systems of matter, of course? No. And this whole history, this sort of search for chemical imbalances, there was a researcher named Kenneth Kendler. He's an editor co-editor-in-chief of a journal called Psychological Medicine in 2005. He sums up this great history, and here's what he says about it. We have hunted for big, simple neurochemical explanations for psychiatric disorders, and we have not found them. Now, what's the importance of this? There's many importances. One is this. We have a paradigm of care for use of the medications that's predicated on this understanding that there is a chemical deficit. The drugs fix it like insulin for diabetes, and that's why you need to take the drugs for life. But I assure you, if you all did the same research, you'd come to the same end I did, and then you see the problem. We're operating under a delusion. In other words, I told you those survey data, 87% of Americans now understand that chemical imbalances causes depression. Now, that's a societal delusion. That's number one. So that's a bit of a betrayal in my book of people. You would never tell people that they have a defective heart when they didn't, right? So this is where you start getting into bad medicine in the sense of that story was used to market the drug, but it wasn't a scientific story, but it leads to people being told that they have a problem they don't have in terms of this known biological problem. That, I think, is a betrayal of patients. It leads to bad medicine as well because, frankly, many doctors believe it as well. They do believe it's like insulin for diabetes. By the way, real quickly, I was given a grand rounds at the Massachusetts General Hospital, which is associated with Harvard Medical School, about 3 weeks ago, and this thing came up about how I was sort of yelling at them, or not saying like, you misled the public. You know what they told me? we stopped telling that story 25 years ago. That's an outdated model. And I said, well, I don't think the public got the message because we still believe in it. So how do drugs act on the brain real quickly? Let's go to antidepressants. So the antidepressant Prozac blocks the reuptake of serotonin, right? The brain has these extraordinary compensatory mechanisms. And in essence, the brain says, uh-oh, I have a bit of a problem now. My system's not working in normal fashion. So the brain, the drug in this instance is trying to accelerate serotonergic transmission, right? What the brain, that's what the drug's trying to do. What the brain does in response is put down the brake. And it puts down the brake in two ways. After you go on an antidepressant, your presynaptic neurons, at least for a time, will start putting out less serotonin than normal. Okay? That's one thing. And then the density of your receptors on the postsynaptic neuron for serotonin will decrease in number. There'll be a reduction of maybe 30, 50, 75% in the density. And you can see why. Drug puts down the accelerator, the brain tries to compensate by putting down the brake. And this becomes the new balance. And other drugs, imagine antipsychotics. Antipsychotics work by blocking dopamine in the brain, right? That's acting as a brake. So what does the brain do? It tries to put down the accelerator. At least for a time, the presynaptic neurons put out more dopamine than normal, and the postsynaptic neurons increase the density of the receptors for that neurotransmitter. So there's always this sort of yin and yang. The drug tries to accelerate, the brain puts down the brake, and vice versa. And in 1996, Stephen Hyman, former director of the NIMH, wrote this beautiful paper called A Paradigm for Understanding Psychotropic Drugs that said exactly this. He said these drugs work by perturbing neurotransmitter systems in the brain, and in response to that perturbation, the brain undergoes compensatory adaptations, and at the end of this process, the brain is now functioning in a manner that is, quote, qualitatively as well as quantitatively different from the normal state. Now, that doesn't tell you anything about whether these medications are going to be good long-term or effective or not, but I think it does tell you this. It's not a normalizing function. It's not like insulin for diabetes. That's number one. Two, once you have this new understanding of drugs, you can see why they might have a lot of side effects, right? Because they're abnormalizing function. Three, I think you can see why once you're on the medication, it can be so problematic to come off. Your brain has adapted to the presence of that drug. And just go back to that accelerator brake analogy. Let's say the drug is like an SSRI. The accelerator is down. Your brain has gone into this low serotonergic state. Now remove the accelerator. You do actually have this imbalanced state. So it's just a different conception. And I think you can also see why they might be problematic over the long term. Now, real quickly, at the beginning of Anatomy of an Epidemic, I asked this question. Is this paradigm of care working? So forget whether or not it's true. I do go into how we came to believe this, but is it working for us? And one of the things I looked at is just the number of people on disability due to mental illness, and this is, say, on government disability. Has it increased? Has it ameliorated? What's happened since 1987? And what you find is in 1987 there were 1.25 million adults on disability due to mental illness in the United States. 20 years later there were 4 million. So there was a tripling of the number of people on mental illness. The rate increased from 543 per 100,000 population to 1,320 per 100,000 population. It's more of a doubling of a rate. Now, I'm not going to go into this, but by the way, if you look at what's happening in Iceland, huge increase in the number of people on disability. You see it in the UK, increase in the number of disability in this last 20 years. I tried to get the Irish numbers. Ireland, you do have a rise in disability, but it doesn't segregate it according to what's the cause. But if you could segregate it, I bet you would see a remarkable increase in disability due to mental illness, mental disorders, since 1987. So that tells you, I think, from a societal point of view, it's really not working for us. We're seeing rising disability numbers. Oh, by the way, today, How many people in this room would you say? 250 people? Does that sound right? In the United States, 850 adults are going on disability every day. Adults. In kids, in 1987, there were 16,200 children under 18 on disability due to mental illness in the United States. There are now more than 600,000 as we've been diagnosing more kids and putting on medication. And if you follow those kids forward, you find that when they hit age 18, they're going right on to lifelong disability. So you see diagnosis, you see medication, and you sort of see this career of a mental patient sort of stretching out before them. That raises questions such as this. How do these medications affect the long-term course of major mental disorders? That's number one. And I try to answer that question for 4 disorders in the book: depression, anxiety, schizophrenia, and bipolar disorder. It's a long story how you do that, but I think, by the way, this is the first book that really tries to see how do medications shape the long-term outcomes. Because the way drugs get approved is, do they affect short-term, do they suppress symptoms over the short term better than placebo? That's why they get approved. And then once they're approved, the evidence for long-term use comes from what is known as relapse studies. You take people who are on the medication, doing pretty well, and then you abruptly withdraw the drug from one group, and you keep the other group on the drug, and you look who has a return of symptoms more quickly. And it's the drug withdrawn group who has a return of symptoms. But as you know, that may be a drug withdrawal effect. It may not be a return of the disease. And the fact is, most of these studies are done with abrupt withdrawal. So anyway, that evidence base doesn't tell you anything about, are you improving the long-term course of these disorders? And I don't have time, and usually what I do is this very scientific story about how that plays out. But again, I think it's, in this book, is the first time I've really tried to do that. And I will tell you what I think the evidence base shows in the long-term outcomes literature. I think time and time again, yes, you do have short-term symptom suppression that is better than placebo. But over the long term, in the aggregate, and by the way, I want to emphasize this, I do believe the drugs help many people over the short term in acute periods of distress. I also think there are some people who are good long-term responders, and therefore there's a place for them in psychiatry's toolbox. Nevertheless, in terms of, if you try to flesh out what is the natural recovery rate, right, of, say, of unmedicated depression or unmedicated manic depressive illness, or even unmedicated psychosis, and you look at those outcomes in the aggregate, I think the science is pretty clear or pretty consistent that, in fact, our paradigm of care worsens those target symptoms over the long term. People are more likely to be 5 and 10 years later still suffering from those symptoms than in unmedicated cohorts, just in the aggregate. That's one thing I believe the research literature shows. I think, second of all, there is a significant percentage of patients who enter with a milder problem, let's say depression. They go on an antidepressant. There will be a significant percentage that actually will have sort of an adverse reaction to the antidepressant, specifically a manic episode, and they will move to a bipolar category. And actually that pathway is pretty well established now, and we'll talk about the bipolar numbers in just a second. And then Pat talked about something else that's really showing up. We got a really big early death problem now, at least in the United States, with the seriously mentally ill dying like 25 years earlier than normal. They're dying at the age of 56. So we're now also seeing with this paradigm of care a lot of physical problems. You are seeing with people placed on the antipsychotics in particular, or long-term benzodiazepine use, some significant cognitive decline over the long term, and then we have early death. So I don't have time to go over that, but I think that's what the main science shows is, rather than improve long-term course of these disorders, it actually tends to make disorders that were more episodic in the past into more chronic disorders. And let me just give you an example of some of the many major studies that I uncovered or found in the medical literature that you never hear about. So, for example, the World Health Organization ran a study of schizophrenia patients beginning in the 1970s, 2 different studies. And each time they found that outcomes in the 3 poor countries of the world, specifically India, Colombia, and Nigeria, were much better than in the rich countries of the world, U.S. and other rich countries. In fact, the World Health Organization concluded that living in a developed country is, quote, a strong predictor that you will never fully recover from schizophrenia. So think about that. Now, after the first such study, the World Health Organization investigators did hypothesize that maybe the reason for this was that patients in the poor countries of the world were more medication compliant. So they looked at medication usage, and what did they find? That in the poor countries, yes, they did use antipsychotics over the short term. They stabilized people that well. But over the long term, only 16% of patients were regularly maintained on antipsychotics. Well, of course, that is the standard of care here. So what do you see in that study? At the very least, you see some association with much better outcomes in countries where the standard of care isn't regular use of the meds. Another study related to schizophrenia was done by Courtney Harding. She followed a group of patients released from the back wards of Vermont State Hospital in the early 1960s. These were chronic patients, okay? They're not going to get better. Well, she reports in the 1980s really good news. 1/3 are no longer schizophrenic. They are asymptomatic, they're working, socially engaged, etc. All those in that category had gotten off medication. So as she concluded in that study, it is a myth that people with schizophrenia need to be on medication all their lives, and in fact may be a small minority. That's another study you don't hear much about. Third, we just had a study published in 2007. It's a long-term study of schizophrenia and outcomes and outcomes of other psychotic patients. It was done by Martin Harrow at the University of Illinois College of Medicine. Beginning in 1978 to 1981, he began following 145 patients diagnosed with psychotic disorders, 64 with schizophrenia, 81 with other milder disorders. If you look at the purpose of this study, it's a prospective study, is to figure out over the long term what happens to those patients who ignore advice and go off the drugs. Now, the expectation, I think, is going to be it's going to be a bad outcome, and they expect to see a lot of problems. Let's start with the schizophrenia patients. And here's what he does. He just follows them up. Everybody treated with drugs in the hospitals, right? And then he just follows them up. Then he looks at how they're doing at 2 years, at 4.5 years, 7.5 years, 10 and 15. He looks at their working. Have they been in the hospital? Are they asymptomatic? And are they using medications? At the end of 2 years in the schizophrenia group, roughly 25 of the 64 patients were off medication. And as a group, they were doing slightly better than those on medication. And now we get something in the research literature you don't ever see before. What happens between year 2 and year 4.5? What happens is that off-medication group on the whole gets a lot better. It's as if they're recovering on the whole from schizophrenia and psychotic symptoms, whereas those on medication don't, such that by the end of 4.5 years, the recovery rate for those off medication is 40%. The recovery rate for those on medication is 5%. He follows that forward through the 15 years. At the end of 15 years, here are the outcomes for these schizophrenia patients. Those on medication, off medication, 40% in recovery, 44% so-so, he had the second category, 16% uniformly poor. On medication was like this, 5% in recovery, roughly 45% so-so, 49% uniformly poor. So as if there was this shift to chronicity. That was one finding. He also looked at whether they were suffering active psychotic symptoms. At the end of 10 years, roughly 70% of those who were continuing to take the meds were still suffering psychotic symptoms versus 28% of those who'd gotten off. That was the same difference at the end of 15 years. Now, this story in the medical literature is spun. I'm just telling you the actual data. He also had what he called good prognosis schizophrenia patients, and it was people with a better sense of self. He looked at those who got off, who stayed on. The good prognosis who got off did better. He had bad prognosis patients. He looked at who got off, who stayed on. Those who got off did better. How about that other psychotic disorders group? And this was really schizoaffective disorder, mania with psychotic features, and unipolar depression with psychotic features. Same sort of thing. At the end of 2 years, those off are doing a little bit better, but then there's this big divergence by year 4.5. Half, by the way, of those with other psychotic disorders got better, and at the end of 15 years, those off were basically, as a group, in the recovered category. A real note of optimism. Whereas those who stayed on were suffering a lot of functional impairment. And here's how the 4 groups lined up in this study that is unique in the literature. The best at the end of 15 years was other psychotic disorders off. Then it was schizophrenia off. In other words, schizophrenia off did better than other milder disorders on, and then the worst was schizophrenia on. There could be a lot of interpretations of this study, right? And if you talk to Martin Harrell, he says, listen, I believe the study showed that the drugs help people stabilize, and then it shows at the very least there's a large subset that would do better off. Did you hear about this study? Anybody? Okay, that's the problem. That right there is the problem. This was an NIMH-funded study. It was meant to look at this question. It came out in 2007. No American newspaper published it. The APA did not put out a press release. The NIMH did not put out a press release. They didn't put it on their website. And NAMI didn't publicize it either. And I ask you this. Imagine it's reversed. Imagine that the results are that the recovery rate for those on medication is 40% and off medication is 5%. Would you know about that? It would be in textbooks, right? The first time this study appeared in any American newspaper was after I gave a talk, like a year later. And again, my point here is, and I'm going to try to finish this up in about 4 or 5 minutes, or actually, we need this information. That's the type of information in the book. We need to incorporate that into our understanding of psychiatric disorders to sort of build a new future. Anyway, because I am running long here, there are something like 16, 18 studies of that sort. Longitudinal studies of depression, schizophrenia, manic depressive illness, etc., where time and time again you actually see pretty good long-term outcomes for the unmedicated group, actually better than the medicated group. And they just never, ever get announced. And that's the hole in the information that we really need. And you'll see if you read the book I talk about in the solutions section. What's the solutions section is? We need to have a free flow of information. And I really want to emphasize this. I believe the medications have a place, big time, both short-term and some long-term. But I think to figure out that place, you have to have all this information. That's what good science and good medicine relies upon. Just to look at the solutions, 2 solutions. What can good science do? Western Lapland, beginning in 1992, revised its medication protocols for first episode psychosis. And what they began in 1992 was this. We're not going to put our first episode patients on antipsychotics right away. Because history, and I could go into that history, shows that many people, if given psychosocial support and care and time, will recover from that psychotic episode and not go down a chronic path and not need medication. So you need this escape valve right at the beginning of that first episode. Now, if after 6 weeks people aren't getting better, then we'll put them on medication. We'll use that for a time, and then we'll have a second moment in our protocol where we'll try to get people off. So the goal actually is to get people off, but we'll end up with some people on long term. By the way, and this will go to this other solution sections, if you go to Western Lapland, they say psychosis is not caused by, it's not in the brain. It results from the in-between spaces of people, and once you have that conception, you can see the need to heal those in-between spaces. Here's their long-term results. At the end of 5 years, Harry's about to give me the fishing hook, and I'm almost done here. At the end of 5 years, 80% of their first episode patients are working or back in school. Only 20% have gone on to long-term disability. And here's their medication use. 33% have been exposed to antipsychotics and 20% in the 5 years. In other words, 66% have never been exposed and 20% are taking them long term. The beauty of this story is I don't think it's an anti-medication story, right? It's sort of a best medication use. They've learned about for whom, for how long, and they now have the best outcomes in the Western world. I could tell you a story of science as to why I think that's supported in all sorts of other science. So I think that's the hopeful thing, and I think the charge for you all here is this. Become informed about how these drugs work, what we know about the biology, and do become informed about these long-term outcomes data. And then as you teach and as you discuss, you can work it into your protocols. And finally, Anatomy of an Epidemic has stirred some nice discussion. There was a sort of a national conference in Portland a couple of weeks ago led by psychiatrists about rethinking protocols. And here I think is, and there's a new one coming in New York in a couple of weeks, here I think is the vision that is arising for the future. Right now we've had this paradigm of care where drugs are at the cornerstone of care, right? Ever since 1987. Got to be on your drugs for life. And then we have these alternative therapies out here sort of as an adjunct, whether it might be, social support, yoga, exercise, nutrition, helping people get jobs. The idea is to flip those. So you put psychosocial care right at the heart of things, helping people get work, shelter, good nutrition, exercise, etc. And then you figure the meds should be an adjunct. Remember, they're not fixing anything known to be biologically wrong, and you figure out when to use them, for how long, that sort of thing. And the final thing is, what I think is so beautiful about this is this. This false story we've told about chemical imbalances creates this idea that over here there are mentally ill people, and over here there are normal people, as if there's some sort of line here. One thing I'm quite sure of, if you're over here in the normal status, if things go hard for you, you have setbacks in love and employment, etc., whatever it might be, it's pretty easy to move over here and to get a diagnosis. But what history and science and life tells us as well is you can move here and you can have psychotic symptoms, depression, etc., and with the right psychosocial care and maybe the right use of medications, you can move back here, meaning that it's not a matter of just living with mental illness. You can just get better. You can just, it can be an episodic thing. And the beauty of this is, this conception, which I think is scientific, encourages a sense that we're brethren. In other words, it's not the other, we're not going to fear that, but that we're all in this together. It breeds this, to be human, in essence, is to have the capacity to become depressed, to go mad, that sort of thing. So thank you very much, and sorry for going on too long.